Oh my gosh, I have a sweater now. Okay, so we'll just piggyback. We ran into some technical issues, so there will be in parts, but we'll kind of get through because we don't have a lot of space, right? So going into what's going on in the adverse effects in terms of EPS extrapyramidal symptoms, secondary Parkinsonism. Uh, all that has to do with is these drugs definitely target dopamine receptors, right? So they're lowering the quality or the ability of dopamine. So when we don't have a lot of dopamine, as seen in the neurotransmitter slides, we could see that you get Parkinson's symptoms, right? So that's the tremors, muscle rigidity. But the ones that we really should make a big emphasis on is the tremors because that happens a lot with Parkinson's. The stooped posture, right, hunching kind of over, and the shuffling gait because of that inability to have good motor control. Tardive dyskinesia, full disclaimer, it is not an instant thing. It happens over time. It's just a unfortunate consequence of using antipsychotics over time. And usually they could show up a lot of facial stuff. Definitely, whenever you think of tardive dyskinesia, think of just a lot of facial stuff. Bizarre tongue movements, facial movements, lip smacking, worm-like motions of the tongue, puffing of cheeks, and controlled chewing movements, or uncontrolled, I should say, right? So going into these first generation antipsychotics, right? So the big things behind them is that, as mentioned, they do break down into two different types of classes. There's phenothiazines, non-phenothiazines. As mentioned, phenothiazines happen to be a low potency. They're the most effective treatment for positive symptoms, and that's for both in terms of schizophrenia. Since phenothiazines have a lower potency, they happen to have a little bit less extrapyramidal symptoms, but they have a lot more anticholinergic effects, a lot of orthostatic hypotension, and sedation. On the polar end, the opposite, non-phenothiazines are high potency. So going into this is directly from the book, right? They have the same efficacy as phenothiazines. However, and the instance is they have lower instances of sedation and anticholinergic effects, but because they have higher potency, that means they target those dopamine 2 receptors much more than phenothiazines. There are more risks for extrapyramidal symptoms, right? Especially with older adults, right? They're usually a lot more frailer and not able to adjust to changes, right? Generally, there's no advantages between either or, right? It's just which one's going to work, other than the fact that non-phenothiazines happen to do less sedation and less anticholinergic effects. They have the same mechanism of action. It's just one is more potent than the other, right? So going into phenothiazines, everything's color coded in an attempt to kind of make it more understandable, right? So big thing, it's blocking the positive symptoms of schizophrenia, and we'll get into the MOA a little bit later. Obviously, it's being used for severe mental illness, right? Psychosis, many adverse effects, right? So we said phenothiazines, they are not as potent. So anything in red you see here is an EPS. We've already covered those before, so I'm not going to go into it to save some time. But when it comes down to, gray box, again, purple underline, anticholinergic effects, there it is. We already talked about it. The less potent they are, they just happen to have more anticholinergic effects, more blocking of alpha 1, which is where we get the hypotension and orthostatic hypotension. Disparity is just, it can make suicidal tendencies a lot worse, if I recall correctly. And sedation, same thing, sedation for the anticholinergic, and what happens because they're not as potent. Sexual dysfunction as well, including how for men usually it could lead to gynecomastia, galactorrhea, basically meaning milk production. Same thing can affect with women. They could also get abnormal menses, so that can also be an impairment for them. And then also galactorrhea, because dopamine 2 receptors, again going back to the neurotransmitter slides, those are in charge of keeping prolactin down. So if we're blocking those receptors, as we see right here, dopamine 2 receptor antagonists, they end up causing more prolactin creation, which is where the breast production is created, and the breast milk production as well, right? So obviously, what it's doing, it's doing symptomatic relief of positive symptoms of schizophrenia, helps also control mania as well. That's why antipsychotics are also indicated for bipolar disorder, specifically Gen 2 because they're safer, but it also helps out with schizoaffective because again it has properties of psychosis, right? Chlorpromazine must be taken for 7 to 8 weeks. Again, same pattern we've been seeing before. These all these drugs take time to work, right? Extreme agitation, right, is a different indication that requires an IM injection or an IV injection that works within minutes. So that is the only difference, right? When taken by PO, medication, it takes weeks for it to work. However, especially how we've been seeing in clinical at times, depending if there's been some kind of acute event, they would give an IM injection of some kind of antipsychotic, and it usually sedates within minutes. So there is a difference. Be aware, onset of action is different, obviously, compared to an injection or a pill. So from there on out, right, chlorpromazine could also be used to control severe nausea and vomiting. We've seen this before all the way back in first semester to kind of jog your memory a little bit. Peak antipsychotic effects take as long to cover in 6 weeks to several months. So unfortunately, again, this is one of those medications you have to take over time, right? So going into this, right? Obviously, don't crush anything. Sustained release. So in IM injection, this one is having a specific like instruction, so we should be careful about it. Give it deep IM, and it's supposed to be on the upper outer quadrant of the buttocks, right? We close up into we split it into fours. That means this one, the one on top right. And the patient should remain supine for 30 to 60 minutes. Why is that? This medication happens to have an alpha 1 block, meaning again, alpha 1 is in charge of vasoconstriction. If the vessels can't constrict, then they'll stay dilated. The patient can have a risk for a fall because of hypotension. So that's why they remain supine for 30 to 60 minutes. That's a big safety thing. So we got to keep in mind of that. Um, the medications has to be gradually withdrawn over 2 to 3 weeks, similar to that washout period we've seen with MAOIs. And if it is abruptly removed, right, or at times, depending like how it's withdrawn, or because our body's kind of going through those like problems, the complications with withdrawing, nausea, vomiting, dizziness, tremors, or dyskinesia can occur. Right, it's kind of standard stuff when these medications are stopped, especially abruptly, right? Gold box, right? That means it's a unique indication. IV forms should be used only during surgery and or for severe hiccups. Kind of interesting. Never really seen that one before. So that already is like a very unique indication that we should watch out for. Little tornado, obviously that means not for pregnant women. Look, see, there it is. Strong blockade of alpha adrenergic receptors, obviously alpha 1 and 2, but mainly we're watching out with 1 because of the hypotension risks. And it has a weak blockade of cholinergic receptors, making it a weak anticholinergic. Regardless, there is going to be anticholinergic symptoms. One of the most common complaints with antipsychotics is my mouth feels funny, my mouth feels dry, right? So the big things, right? Common adverse effects: dizziness, drowsiness, orthostatic hypotension. They're just going hand in hand with everything we just talked about right now. Right. So going into it, right, EPS can occur more commonly in older adults, women, and pediatric patients who are dehydrated. Why is that? Right. When a person is dehydrated, especially if they're a little bit more on the frailer side or more susceptible to issues, if they're dehydrated, right, they don't have enough fluids. The fluid works as a dilutant. So if the fluid isn't there in our vessels, right, to dilute, our the medication concentration is a lot more pure. Obviously that means more toxicity. That's where the EPS, the drug, works stronger. You get more side effects from it. um, Off of the bat, look at this. NMS, right, neuroleptic malignant syndrome. It may occur. Patients taking chlorpromazine who are exposed to warmer temperatures have a risk of NMS. NMS, it seems like it has a big emphasis on fevers, so that is usually the biggest, like probably earliest warning sign. This black box warning, and these are going to be applied to absolutely every antipsychotic without a doubt, is older adult patients with dementia related psychosis are not to be using any of these antipsychotics because they are all at increased risk for death. That is a blanket statement for all antipsychotics. I noticed that off of the bat, off of all the slides. Contraindications, right? Not to be used for alcohol withdrawals or when in a comatose state. So this is very different in comparison to the antidepressants that we saw that could be used for alcohol withdrawal or cocaine withdrawal, but not exactly for antipsychotics. Completely different intervention, right? Um, Caution should be used for anyone with subcortical brain damage, bone marrow depression, because there are in antipsychotics, it's very rare and it's a little bit more prevalent in second generation drugs, but there is a very rare risk of a granulocytosis with these medications. So what does that mean? Blood dyscrasias, anything related to bone marrow suppression, right? Low platelets, raw RBCs, anemia, issues with white blood cell production. So watching out with that, right? And Ray's syndrome. Big thing that I'm kind of taking away from here is that subcortical brain damage, right, has to do with the CNS, especially the brain, right? All this targets the brain. So it's kind of the same way how when we look at nitroglycerin, because it drops the blood pressure and it can make someone a little bit altered in their consciousness. And if they already have brain trauma, that might not pair well because you can make it's a chicken or the egg thing. It's like, are they altered because of the medication or are they altered because of their condition? And then you could also make it worse. So chances are that's maybe what it's relating to, right? Drug-drug interactions, right? So concurrent use with other sedative medications like phenobarbital, the very strong GABA agonist, should be avoided, obviously, because it causes more sedation. Taken with TCAs, it can cause an elevated blood pressure, which we've already seen TCAs are a big thing to watch out for when it comes to cardiac history and anybody that is susceptible to any cardiac events. So watch out with that. Anti-seizure medications can actually lower the seizure threshold. So these, just like we've seen with a couple other ones like TCAs and SNRIs, can lower the seizure threshold. So very careful with this, right? Lab tests, they can increase cephalin. Well, basically, they can increase liver function tests. That's really what I was trying to get at. I just didn't highlight correctly, but that's what I'm trying to get at. They all are going to affect the liver one way or another, and it could cause false positives or false negative pregnancy tests as a result. But obviously, the main idea is to stay away from pregnancy when on these medications. Kava St. John's wort. These are just classic over-the-counter herbals that we have been seeing for all these mental illnesses. So they should be avoided because they can increase the risk of dystonia. We've seen it before, right? NMS. We've seen it with serotonin syndrome, acute dystonia as well. So it can contribute to the issue because of their properties and what they have in their neurotransmitters that they eventually create, right? So there is no treatment for overdose, and for the most part, this can be kind of a blanket statement for all of them. So might as well just kind of make a habit of knowing it now. EPS can be treated. They can be treated with anti-Parkinsonism drugs. What that's saying, you're giving dopamine agonist drugs, right? Because these are, long story short, a dopamine antagonist which can cause Parkinson's. Anti-Parkinson's, right? You're going against Parkinson's, you're trying to treat it, you're going to try to increase the concentration of dopamine one way or another. So, anti-Parkinsonism drugs can help out with EPS. Barbiturates can help sedate a little bit, right? You're going to need something stronger to control. Just obviously, we have to be very careful with the other one because of the warnings with drug-drug interactions. Anticholinergics. Why is it? This drug already does anticholinergics. Why would it be that an anticholinergic would be necessary in a treatment of an overdose, right? So how I'm taking it away is that regardless of the fact, acetylcholine is used, as we've seen before, in different methods to control muscle contractions, right? So if we use something that, because in EPS, right, acute dystonia, neuroleptic malignant syndrome, something like that, it can cause a lot of muscle contraction, a lot of muscle tension. So the point of the anticholinergic, I would imagine, is because blocking out those acetylcholine, like the ability for acetylcholine to work, helps kind of relieve that muscle contraction. So being very careful with that and using it for that in that sense, right? Avoid producing any respiratory depression. Basically, it's saying monitor, 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 right? Here's some first generation drugs. Luckily, there is a pattern. I did underline specific things I noticed when it comes to the pattern behind these drugs. Anything that is a phenothiazine will usually end with phenazine, so fluphenazine, perfenazine, or they will have this chlor in the end, right? Or in the beginning, I should say. Chlorpromazine, prochlorperazine. So a lot of that, and look at that, it's compazine. I wonder if that kind of brings up some memories from first semester, right? But there is a pattern to this. So I did underline what is could be noticeable. Going into role of the nurse, right? Liver kidney function, just to avoid any toxicity. Monitoring for EPS, but be aware it is not a reason to discontinue the medication off the bat if there is no life-threatening things going on. Obviously, if there is, we put life over limb, and that way, so but again, it's just we need more context in the situation. Non-phenothiazines, right? Honestly, looking through it, I haven't really seen a lot of other examples, either from the book or what was mentioned in class, because these are the slides. Haloperidol seems to be the one that we really got to care about when it comes to non-phenothiazines. Brand name Haldol, right? So same action as we went before, blocks dopamine type 2. It's same indication, severe mental illness, the psychosis, and all that kind of stuff. Adverse effects are very similar. The only difference, again, the only difference is that this one happens to have a higher tendency of extrapyramidal symptoms compared to the anticholinergic effects and the orthostatic hypotension and the sedation that can occur. So take those three away. They're still possible. They're just not as prevalent as EPS when it comes to this, because we're going to go into it in a little bit in the next slide. But obviously, it's the management and for anything, any acute or chronic psychotic disorders, Tourette syndrome, children with severe behavioral problems or unprovoked aggressiveness and explosive hyperexcitability. All of this, my main takeaway, it's a lot of over CNS stimulation when it comes to being aggressive or having those psychotic features. So being very, very aware of those kind of things kind of helps out understand, because it ends up kind of making more of a blanket statement to help kind of catch things on a little better. Look at that. Haloperidol, it's 50 times more potent than chlorpromazine, right? Same efficacy at relieving the same symptoms, just some drugs work better for one than the other, right? Or one patient than the other. Haloperidol, long acting, it is a medication that is given by IM, and it takes 3 weeks for it to work. IM or subcutaneous injection. So it could be seen that this is probably, it's something that could be used in a sense for patients that, like, similar like how when people take warfarin, they might take heparin for the time being because warfarin takes time to work. Heparin works a lot more instantly or a lot more sooner. So it's taken just to kind of get things jump started. Chances are this is what it's talking about, especially for those who are uncooperative or unable to take oral medications. Obviously, do not abruptly discontinue or the severe adverse effects may occur. Um, Same thing, just take the medication as indicated. Basically, is what it's saying is that the patient needs to be compliant with the meds. Surprise, surprise. Again, if they don't take their PO, they could get the long-acting one, the IM injection. Right? There's that tornado, not for pregnant women. Adverse effects, right? Haloperidol produces less sedation and hypotension than chlorpromazine, but the occurrence of EPS is high. This is, I'm just repeating myself because I'm just trying to hammer it in over and over. Hopefully that kind of starts catching things on, right? And then the incidence of NMS, which is a type of EPS, the most extreme EPS, can occur, the life-threatening EPS. This gray box is just repeating what we said before about patients who are with that have psychosis related to dementia, right? Contraindications, Parkinson's. Obviously, if someone has Parkinson's, their dopamine doesn't work, so you don't want to give something that is basically canceling out or making their dopamine work even less. Whether it's the receptor or the neurotransmitter itself, don't give it to them because you're going to make the Parkinson's worse. Seizure disorders. We saw that already in the other chlorpromazine. We saw that the seizure threshold can be dropped. So already not indicated for that because it can make seizures occur. Alcoholism, we saw it can't be used for those kind of things. and then severe mental depression because the disparity can make it worse and even lead to possibly suicide, right? Haloperidol interacts with a lot of different drugs. Main thing is that haloperidol decreases in absorption or effect when taken with aluminum and magnesium containing antacids. What a surprise. A lot of medications are affected to that because they remove that acidity that the stomach has. So obviously it's going to impair it in some way. Levodopa happens to be a medication that increases GABA in the body in order to help out. It's the biggest indication is for patients with Parkinson's. Obviously, if you're giving a Parkinson's drug and a drug that can cause Parkinson's, there's going to be a conflict here, right? So levodopa seems to have the more, the stronger sense, the body has more affinity to levodopa, so it could decrease and lower the effect of the antipsychotic instead. Phenobarbital, phenytoin, right? Those lower the levels. Again, could be just that the body just doesn't really have an affinity for this drug. And finally, rifampin as well. Beta blockers, right? Funny enough, beta blockers can increase the levels of haloperidol. That one's a little bit unique, and it could lead to toxicity. So that one's kind of the outlier. That's at least how I understood it. The sentence structure may be a little bit weird, but there is a little bit of fine print there. And it can inhibit the action of centrally acting antihypertensives. We've been seeing that a lot of these drugs can mess with antihypertensives or make them cause any adverse effects, or just not give the benefit, but only the adverse effect. So kava, stay the hell away from kava, valerian, pretty much anything that is those over the counter St. John's wort stuff. Stay away from all that stuff, right? Because it increases the effect of all of these drugs that we've talked about, right? Um, Treatment of overdose, right? Our anti-Parkinson's medications, basically just dopamine agonists. And then the hypotension should be counteracted with IV fluids, plasma, concentrated albumin, or vasopressors, right? Different ways to increase the blood pressure. Same thing before, we've talked about it. Give anticholinergic medications in order to help out with that. It could be possible to use phenobarbital to sedate, but it helps out because EPS gets treated in that sense to prevent those muscle contractions. Because after all, we've talked about, oh, this is just repeat, but after all, when we talked about NMS, the body, the contractions can be so strong that the muscle rips, right? So we don't want that to happen. Haloperidol, so I mainly highlighted this one because it seems to be the only one that really is cared about when it comes to the first gen non-phenothiazine antipsychotics. Pimozide is the only one I've really seen. Other than that, I have never seen loxapine and thiotixine, or however the heck you say it, but I've mainly seen Haldol, the haloperidol. So honestly, I'm making more of a bigger emphasis on that, and it does make it a little bit easier to remember. I guess Pimozide, you're just gonna have to memorize that if you're able to. Antipsychotics, right? So these, unfortunately for me, I just sort of had to memorize in terms of the names. These are some of the most common ones: quetiapine, Seroquel, risperidone, Risperdal, which is actually more of the choice drug treatment because people happen to have much more better success with these drugs because they're safer. They're second generation drugs. Atypical, why are they called atypical? Atypical antipsychotics happen to treat positive and negative symptoms of schizophrenia. And finally, we have olanzapine, which is Zyprexa, right? At least they kind of follow a similar naming structure. But there is a certain outliers that just don't follow it, and you're just going to have to memorize it, right? And I guess just for the time being, if you guys recall from the video that we watched in small group, right, the documentary, the patient said that originally he was on Haldol, right? And then he looked kind of a little bit more on the skinnier side. And then he said he started, if I recall correctly, started taking Seroquel. And then in the next slide, you actually see that he got a lot more, he got bigger, he gained weight. Keep that in mind when we talk about side effects. Prototype drug is risperidone, right? Risperdal blocks dopamine type 2 receptors. It could also block serotonin and alpha adrenergic receptors, right? They're indicated heavily for the same thing we talked about: schizophrenia, severe mental illness, and treats both positive and negative symptoms. Adverse effects are fewer than phenothiazines and non-phenothiazines. So basically, fewer side effects, or fewer adverse effects, I should say, than first gen drugs. But obesity, like we saw in the documentary, and its risk factors of obesity, high cholesterol, hypertension, maybe even renal damage, is to be monitored. Could have sworn I said diabetes. I think I did. Well, diabetes. If you guys didn't hear diabetes, right? And that's a big thing because one of the side effects is increased blood sugar. So blood sugar management is very big and has to be watching out for anybody that has diabetes, right? So look at that. It's a first line drug because it's safer. First line means it's safer, right? For the treatment of schizophrenia, acute mania associated with bipolar disorder, right? Again, we saw that it is used with carbamazepine, that anti-seizure drug. Risperidone is used with carbamazepine in conjunction to do what lithium does, which is pretty cool, right? Or irritability in children with autism, right? It reduces the excitement, paranoia, and negative behaviors associated with those with psychosis, right? Same thing, right? There's a blockade of dopamine type 2, serotonin type 2, which targets a lot when it comes to depression. So there's those negative symptoms. Alpha 2, so it kind of helps soothe the body in a sense, or I'm sorry, not soothe the body. It actually kind of prevents the body from being soothed in a certain way. And I'm assuming that is to target the depression side of things. The dopamine type 2 is for the psychosis, the serotonin type 2 and alpha type 2 is for the depression. That's how I'm taking it away, right? And they'll come in for a later kind of discussion, right? For full range of effectiveness, sometimes these drugs are combined with lithium or Depakote, which is valproic acid. The reason why, mood stabilization, it helps out. So it can be paired with them, right? Like we've said before. And it could be used with, seizure drugs or lithium itself. The IM, so mainly I'm not necessarily sure if there's going to be mention of IM stuff, but I did highlight some things IM injection related stuff. Who knows if it really will come up, but you guys can read that on your own. Several weeks are required for the therapeutic effectiveness. That is for all of them, like I've said, right? When switching from other antipsychotics, discontinue the medication to avoid any overlap. And the big thing is to taper off first. That's the most important thing. All right, guys, we're just going to finish this up. Thankfully, we are now at the last leg of the presentation for chapter 17. As you guys saw, we had to continue off from the last one, so because we ran into some technical errors, so we're just going to finish strong, okay? I even changed his shirt. So what we're gonna go ahead and do is we already covered this part, right? We obviously taper first. Anytime that any antipsychotics, any new ones are gonna come up, we're just gonna discontinue, but we discontinue by tapering because we don't want to do an abrupt cessation, right? The tornado, right? As we've said many times before, if you see that tornado, that basically means it's not for pregnancy. So adverse effects when it comes to risperidone, right? And again, since it's a prototype, it can apply mostly to all other second generation antipsychotics, right? So the common adverse effects are your EPS, right? We talked about how EPS is something that is just occurrent with the use of antipsychotics. Not they're not life threatening all the time, but they can be, right? And that's where it's just explaining the involuntary shaking of the head, neck, and arms. That could be related to Parkinsonism, right? Like what happens when you're taking the antipsychotics. Um, Hyperactivity, right? Because in the sense of what's going on, right? Like this, it could cause, in a sense, like we'll pair hyperactivity with visual disturbances, with what's going on, especially what it's talking about in relation to the MOA of um, a blockage of serotonin receptors. We can go ahead and kind of pair that in the sense of just your body still needs to get messages, right? And because you're blocking them and there's kind of issues that can kind of make the body, it could have like a paradoxical effect, just like we've seen with all these other medications, even though sedation is occurring. Fatigue happens again just because of what happened with we'll pair that up in a little bit with another thing that happens. But nausea, that's very common. Dizziness, we've already said that we're going to pair dizziness and drowsiness with a lot of these medications because of the sedation effect. Um, Fever, that may be related at times, to NMS, and it could be an early sign of it. orthostatic hypotension, because all of these medications generally cause orthostatic hypotension. So it's something to be mindful about. Now, the big thing with these second generation drugs, especially, if you guys can recall from small group in the video, the man who was having the documentary made about him, he was taking Haldol, right? And that was our first generation antipsychotic medication. And then he said that his doctor ended up putting him on, if I recall right, Seroquel, which is quantipine, which is another type of second generation antipsychotic. And you guys kind of saw that he was a little bit not, he was a little bit like skinnier. He was lighter weight on one part when he was saying that he was on Haldol, but then after finishing saying he was on Seroquel, the second generation drug, just like Risperidone, it showed the next scene, and he was a lot bigger. Like he gained a lot more weight. So that's what I want to pair up. If you guys recall that from the documentary, about an increase in weight gain. And then hyperglycemia is also occurrent in these second generation drugs, so it could worsen glucose control in diabetic patients. So already kind of, watching the documentary and seeing that happen, seeing cause and effect like right in front of us, that really helped me just memorize that, oh my goodness, second generation drugs really do make you gain weight. And then obviously, like we saw in earlier slides before, it talks about how there are some, consequences of weight gain: the hypertension, the high cholesterol, of course, the diabetes, and the other issues that can come with it, right? So it's something to kind of help you out with in just being able to kind of identify everything. Black box warning hasn't really changed, right? If anything, this is just explaining what's going on with the black box warning. That's why this gray box kind of encloses everything. So same thing like we've talked about with the black box. If they have dementia related psychosis, they are not to be using this medications. The big thing is that, and here's the reason why: they're at an increased risk for heart failure, which we've already seen these medications be a little bit, tentative when it comes to people that have a history of cardiac issues. Pneumonia, right, because they're not taking care of themselves, they can end up getting an infection, or sudden death. So those are just the explanations of why antipsychotics in general, whether first gen, second gen, or anything, for the most part, they have that black box warning for dementia related psychosis. Any other contraindications include, underlying cardiovascular disease, which again goes hand in hand with everything else that's going on, right? Because they're much more prone to dysrhythmias and hypotension. So, as we're seeing this pattern that antipsychotics generally have a lot of, they just don't, they should not really be paired up with cardiac issues, because, they already cause regularly hypotension, and then already off the bat, if they have a tentative cardiac history, it could lead to, a heart block or some kind of other dysrhythmia. So that's obviously not good. And look at that. Should be avoided with patients with seizures, SI, kidney or liver disease. We've talked about these in first generation drugs. It could be likely that they lower the threshold, right? So it seems like there's a growing pattern of um, these antipsychotics lowering the seizure threshold. And then SI, right? Because again, it's helping in a sense, get rid of those other feelings of, the delusions and everything, and it's kind of just helping out and making things worse because of the disparity that could come in. And then kidney and or liver disease, because obviously with the kidney we can't excrete it, liver we can't metabolize it. But yeah, I guess apologies to clarify with the suicidal ideations. It's just from the disparity that comes with it. The depression could get a lot worse in a sense. So drug-drug interactions, to finish up, right? They should be avoid other CNS depressants like alcohol, antihistamines, sedative hypnotics, opioid analgesics. Makes sense. It's just going to make sedation worse. We did see that antihistamines or just anticholinergics in general can be used for OD, but I'm assuming that's a special case. It's just not something to be used like just a day-to-day kind of thing. Um, they can just increase the adverse effects of the drug, right? Um, there is inhibition of liver enzymes, so it seems like it has an effect to do it, right? So it can increase, it could cause more issues with inhibition of liver enzymes. I'm so sorry, are caused by SSRIs or azole antifungals. It could just interfere with the metabolism the or the excretion of the drug. And then risperidone may interfere with the elimination of clozapine. So that's just another antipsychotic. That's a second generation. That's Clozaril. That's it's just they're gonna basically kind of pair into each other and work synergistically to make things a little bit worse. It's kind of like leading to more toxicity. Finally, lab tests, they're going to increase serum prolactin levels. We did talk about in the other video that these drugs happen to block dopamine 2, right? Dopamine 2 regularly keeps prolactin down, but if you block it, then it'll increase it up. It increases ALT, AST, which is nothing really new. But one of the big things that I wanted to start is that it seems that although, like we've said before in the last video, we talked about how granulocytosis or any kind of blood dyscrasias can occur. It's very rare, but they can occur with antipsychotics. It seems like they're more occurrent in second generation drugs, just like risperidone. So that's the reason why I started 4 times, because it's just something worth to kind of, it's more prevalent to that. It's like how when it comes to extrapyramidal symptoms, they happen more to Haldol than they do with the other second generation drug. So, or I'm sorry, the other first generation drug. It's kind of like that. Which one's more prevalent? So it seems like in what sets apart second generation drugs is that they lead to more weight gain. They can make diabetes a lot worse. Lead to high cholesterol, hypertension, cardiac, like CAD, cardiovascular disease, and stuff like that, or coronary artery disease. And they can cause blood dyscrasias like anemia, thrombocytopenia, so difficulty making platelets or clotting, right? Leukocytosis, so creation of white blood cells, or leukopenia, not enough white blood cells. So it seems like, again, those are the two kind of different things about these second generation drugs. Obviously, treatment for and just little thing, look at that herbal food. It's just repeating over and over. Kava, valerian, chamomile, stay away. They just make things worse, and that's kind of for all our medications that we've went throughout this whole 16 and 17. Treatment of overdose, right? Activated charcoal to help absorb with it, so it just doesn't stay in the body for too long. Sorbitol helps excrete it. So nothing really too crazy that we haven't seen before. It's just a lot of supportive care. It's your standard overdose kind of treatment. It's nothing specific. And then finally, here are some examples of second generation antipsychotics. So it's kind of interesting. Our book talks that ariprazole, and notice that ariprazole has a completely different naming structure for the most part. I would imagine that this would end up kind of leaning more to the same way as ariprazole, this brexpiprazole, but the other second generation drugs would be this acipine, right? I haven't really seen that one, but we're going to see a couple that we do see. Clozapine, there's that Clozaril that we talked about, and olanzapine, Zyprexa. So the big thing that I'm just trying to take away from here is that in the book, it did talk about how, yes, these are second generation drugs. They are atypical. And the reason why they are atypical antipsychotics is because they treat positive and negative symptoms. The thing with ariprazole, and I would possibly imagine due to its naming structure being very similar to ariprazole, this brexpiprazole, that this drug can sometimes, and even in the book, it does it too, and in our slides, this is what we're being told. So I would lean that it happens to be a third generation drug because it's a partial antagonist. So just to kind of make things a little bit clearer, right? So what is it? And this is just a quick teaser for the third generation drug because there's not a lot of info, right? But in the sense that ariprazole, and I would imagine this other drug right here, this brexpiprazole, these drugs work in a partial antagonist action instead of a complete antagonist. When things are a little bit more specific or you add more to the pharmacologic, they cause less side effects because they're much more specific, right? There's less room for error because they're more specific rather than general. So the thing with this is that like picture like a door, right? And picture a room that's full of water, and you open the door, and all the water leaves out because it's completely it's going out in a proper flow. Close it up, right? Completely block it. The water's going to stay inside the room. However, these ariprazole, and I mainly pay attention to ariprazole, but do follow this like piprazole, right? Because they both have it, so there is a naming structure to this. There's a rhyme or reason. They do a partial antagonist action. So imagine that room that had all that water had the door slightly open. So things are kind of leaving out more like in a controlled manner than it is in a crazy, everything's just leaving. So the thing with this is that they're called dopamine stabilizers and they are dopamine antagonists because, the partial block helps kind of avoid any big issues. And we're going to go into why is that. There are adverse effects here, but these are all just general adverse effects that happen with antipsychotics. However, even in the book, which is, I don't know, contradictory to itself, it talks about how in third generation drugs, the side effects are very, very, very mild to the point where they don't even have a lot of really bad adverse effects or just your classic side effects. But we'll touch on that in a little bit, right? So here's some other ones. Look, quetiapine and risperidone. Risperidone is a very unique name, but at least they all kind of fall under this similar, apine. They end with apine at the end, right? So they kind of help out in kind of remembering those. The brand name is a little bit more just you have to memorize, unless you could come up with a good pattern. And then risperidone, you just have to memorize risperidone because it doesn't follow that naming structure. All right, so roll the nurse. Honestly, we're just going to skip this just to save you the time. And then finally, we have our last slide, right? So again, it's going off of atypical antipsychotics, right? But although they, atypical second generation, these are kind of called third generation because they're a dopamine serotonin system stabilizer. They don't do that full block like we just talked about. So riprazole is the one that we're mainly going off of. That's the like kind of the prototype drug in a sense. This right here are the notes I took directly from the book. They control both positive and negative symptoms, so that's why they're still called atypical. However, the way they work is just a little different. They're a little more specific. They do a little bit more than just a complete block, right? They're generally well tolerated. They have a lower risk of extrapyramidal symptoms than haloperidol, that first generation non-phenothiazine, and they have less weight gain issues than other atypicals, antipsychotics, so the second generation drugs. So these are very, very well tolerated. They have less side effects. They have less bad side effects too, or those extrapyramidal symptoms that a lot of people have. Because why is that, right? Why is it that extrapyramidal symptoms happen? Let's kind of bounce back a little bit and let's look at Haldol, right? So Haldol was very potent. Its antagonist action towards dopamine 2 is very, very strong. That's the reason why anticholinergic effects are less with Haldol. The orthostatic hypotension and sedation is a little less with it, but extrapyramidal symptoms is a lot higher with Haldol because of its potency. In this case, it's not even doing a full dopamine 2 block, it's doing a half block. So it's more stabilizing, right? It's bringing it kind of down. So it's kind of helping calm it in a sense. So EPS, the direct origin from it is from the block of dopamine 2. So dopamine 2 isn't really being blocked in this case, so there's less instances of extrapyramidal symptoms. That's kind of what helps out in making these so well tolerated because you have less bad side effects. It's unfortunate that they don't go. It's good and bad that they don't tell us more about it because it's pretty interesting and just like oh wow, that's amazing. But less information we kind of have to know. But at least that hopefully kind of gets things in the head kind of moving and understanding why is it that these are a lot more safer, right? Anticholinergic side effects are virtually non-existent, and look, little happy face. It's good because those are one of the biggest reasons why people don't really want to take these drugs because they're annoying. We've seen it before in those diarrhea drugs. You guys remember the diphenyloxylate with atropine? The atropine is there to prevent addiction because anticholinergic effects are annoying. Um, And then adverse effects are significantly lower. They're still all the same ones we've seen before. There's just the risk is a lot lower. So just keep kind of, piggybacking off of the other ones. It's just this is kind of safer compared to others. And then the general common side effects are your headache, nausea, vomiting, fever, constipation, anxiety. Not really a lot of crazy stuff. So this is what makes them very safe. And then finally, I'm just going to skip this, right? Big thing she said in class: education. Let the patient know that extrapyramidal symptoms are possible, so they don't, it doesn't sideline them and, kind of catch them off guard. And then finally, look at that, two repeats of underlines: compliant with medicines, compliant with medicines. Just it's just that's the big thing with education, because if not, they're not going to get any better. But that's essentially it. That was the last slide. That was a lot. If you guys kind of stuck it out and finished, my props to you guys. Hopefully, it did kind of help expand and understand things. And you guys take care. Best of luck on the exam. Sorry for the technical issues. We'll try to avoid that in future videos. But take care.